So botulism. So this is caused by a bacteria, and it's the toxin of the bacteria that causes the disease, and it's often in the form of food poisoning, sometimes from improper canning, maybe some home canning of foods. Sometimes it's found in honey that can affect infants. So we always tell parents, don't give your 1 year old any, well, one year old or less, any honey. And what it does is so Clostridium botulinum or botulinum, it produces a toxin, and the toxin in the bloodstream blocks acetylcholine at the neuromuscular junction. So it basically causes skeletal paralysis, so muscle paralysis. So these people can come in extremely ill with breathing problems, airway. So what's the most concerning thing for botulism? Airway, breathing issues. Because the muscles that move the eyes are affected. Well, all the muscles of the body are affected, but you can get double vision because the eyes don't track together. You can have complete body paralysis, and that's often what it leads to. So any muscles that are under voluntary control, where you control, can be affected by this. Difficulty swallowing, difficulty moving your eyes, difficulty breathing, all from this toxin that blocks the acetylcholine. The treatment is extremely expensive. It's an antitoxin antibody that we give IV to try and mop up the toxin that's in the blood with this antibody, so they connect together, and it makes the toxin inactive. Okay, so the prevention is the biggest part of this, because the treatment is very prolonged. People can spend months in hospital on extremely expensive antitoxin medication. So proper cooking and preserving of foods, avoiding honey in children and infants less than the 1 year of age. This would definitely be a reportable disease, because you can imagine if you're at a restaurant, you develop botulism. Well, the healthcare unit definitely wants to know about this. This can poison many people and kill many people. So I mean, it's something that's also used, unfortunately, in chemical warfare, right? Because it takes really tiny amounts of these to paralyze people. So here's another infection that, and you'll see it's from the same group, Clostridium. You're going to start to realize that Clostridium is a very unfriendly bacteria, the group as a whole. Yeah, we just mentioned Clostridium botulism. Now we're looking at Clostridium tetani. You've probably, well, we've already mentioned Clostridium difficile. Bit of a nasty bacteria. So a lot of the different strains in this group cause serious disease. So tetanus is what we develop from this bacteria. The vast majority of us have had multiple tetanus shots through childhood, and then boosters every 10 years. So we're really quite immune to tetanus in North America. That may not be the case in developed countries. And typically it's acquired through deep wounds, deep, dirty wounds. So if you scratch yourself with something, that's not really a tetanus prone, because Clostridium likes to live in deep wounds that doesn't have a lot of oxygen. Okay, they don't need oxygen, so deeper wounds are typically where Clostridium tetani is more prone to grow. Now, usually if someone comes in with a deep wound, if their booster is more than 5 years, we'll give them another booster to protect them from this condition. The average incubation, so the time between getting or having the bacteria and the toxin in symptoms is anywhere from 3 to 21 days. So you can see there's a huge variability there. The toxin from the bacteria in the wound is the problem. And it gets into the nervous system, the peripheral nerves within the wound, and it can travel within the nerves to the central nervous system. Okay? And what it does in the central nervous system is it blocks the functioning of inhibitory nerves in the brain. So if it's blocking the inhibitory nerves, the excitatory nerves in the brain can take over. And if the excitatory nerves take over and they're not managed or controlled within this fine balance by the inhibitory nerves, then it's going to lead to severe muscle spasms to the point of actually breaking bones, and seizures, because the brain isn't being inhibited anymore, because everything's in a fine balance, right? So severe muscle spasms all over the body. You can see this infant's back is arching, severe seizures, stiff clenching jaw, arched back, high fevers from the infection, and from recurrent seizures you can have brain damage. And this is all from the toxin. And this can definitely be a fatal disease, since the binding of this toxin in the nervous system is irreversible. So it's a very rare disease now because of immunizations. That is what has protected us, because Clostridium tetani is everywhere. It's in the soil, it's in the ground everywhere. But we've been immunized. We've had so many immunizations as a child to this disease, that we're quite immune to it. So the other term for tetanus is lockjaw. And I'm sure you can understand why we call it lockjaw as well. Okay, so let's talk about another group of, diseases, and they're in the group called polyneuropathies. So poly just means more than one. So polyneuropathies it's affecting nerves all over the place. Typically, it's in the peripheral nervous system, but affecting more than one peripheral nerve. Okay, so it's not like you have pins and needles in one finger. No, you'd have multiple areas of nerves affected in the peripheral nervous system. So just try and group them a bit. We spoke about neurodegenerative diseases. Keep them in your mind a bit straight. Okay, well, Parkinson's was a neurodegenerative disease. Multiple sclerosis was a demyelinating disease in the central nervous system. And now we're going to talk about some polyneuropathies. And a lot of these diseases are very interesting and amazing what can happen to the human body. So Guillain-Barré syndrome. So we call this an ascending polyneuropathy, and it can be fatal. And what happens is, so often this is preceded by some kind of cold or cough or viral infection that you had 2 to 4 weeks before this starts. Rarely, there's a very weak link to immunizations. And if someone's had Guillain-Barré, we'll definitely avoid certain immunizations. The weak is extremely linked, and it's definitely not strong enough to say don't get immunized. No, immunizations are extremely important to protect against so many diseases. So anyway, so very minor link to immunizations. There is this association with when you ask people with this disease, did you have some kind of a cold or something 2 to 3 weeks ago? And what happens, the reason why we say it's ascending is that it usually starts in the furthest parts of your body, so your feet and your hands. And it often starts with tingling and weakness in the hands and feet. And then it gradually goes up the upper limbs and the lower limbs. It starts to go up. So you get more tingling in the upper arms and more weakness in the upper arms and legs. Okay, and we think it's an autoimmune disease, and it's a demyelinating disease of the peripheral nervous system. Okay, remember we mentioned multiple sclerosis? That was the central nervous system. That's a central nervous system disease. This is the peripheral nervous system. And the nerves are demyelinating. So if they're being attacked by these antibodies, so if the peripheral nerves are demyelinating, they're not going to be able to send signals down the nerves. So you're going to get pins and needles because your sensory nerves aren't sending signals back to the spinal cord, and you're going to get weakness because you can't send signals to your muscles to contract. And it can be very significant because as it progresses up the legs and the arms, you get paralysis of your arms and legs, but you also get paralysis of your respiratory muscles. So you can run into significant airway and breathing issues, and often these people need intubating because they can't maintain respirations. So they need to be put on a ventilator to breathe for them. Okay, and recovery is often slow. So you can imagine this ascending paralysis paralyzes your arms and legs, your chest muscles, all the muscles of that you can actively move yourself. So the eyes, the eyelids, the face. There's paralysis there. Again, you're still inside, and you can think, but you just can't talk very well. You have slurred speech. Your arms and legs are weak or paralyzed. And it can also affect the autonomic nervous system. So if it affects the autonomic nervous system, well, that's the system that controls blood pressure and heart rate and bowel and bladder function. So these people are often lying in bed for months on a ventilator. They need a lot of nursing care to make sure they don't get skin breakdown and decubitus ulcers, to manage their blood pressure, to make sure it's not too low or too high. And the biggest issue at the beginning, anyways, is respiratory function. They can go into respiratory arrest very quickly. So airway is number one in this condition when it first starts. The recovery is fantastic if you can get through all these complications of lying in bed for months, and the complication at the beginning of not being able to breathe, right? So I can tell you, I had a case not long ago where someone came in with just some double vision and droopy eyelids and couldn't find very much. And then they came in about 6 hours later with weak hands, weak legs, droopy eyes, and some shortness of breath. And within about 6 more hours, this person could not breathe anymore. So they had to be intubated and put on a ventilator. And then, of course, you're spending anywhere from months to up to a year in a bed. So skin care, pneumonias because they've been on ventilators for weeks to months, blood pressure problems. These are highly time-intensive patients. Okay, and then most of them, 85 to 95%, will make a full recovery if they can get through all these complications. It's treated with intravenous immune globulin and plasmapheresis. So intravenous immune globulin is basically giving a bag of antibodies to try and stop the autoimmune attack on the body. Plasmapheresis is actually taking the blood and filtering it through an outside machine to try and filter some of these antibodies out of the serum and then putting the serum back into the body. So that's the treatment that is tried for Guillain-Barré syndrome. Okay, and this slide is just showing you above a typical nerve with a nice myelin sheath around it, and then a destroyed myelin sheath from Guillain-Barré, the autoimmune antibody attack on the myelin sheath. Okay, another slide on Guillain-Barré syndrome. It's showing you some risk factors in the top left corner. We think it's an autoimmune attack of the peripheral nerves. There's a weak association with immunizations, often preceded by a mild viral infection. So we think there's a link with viral infections. Progresses quickly over hours to days from your hands and feet with tingling and weakness, and then progressing upwards to the respiratory muscles. I don't think I need to mention too much, lower at the lower part of the bed here on this slide, begins in lower extremities and ascends bilaterally, causing weakness. Ataxia is difficulty keeping your balance and difficulty with your gait. Bilateral paresthesia is just numbness, bilateral numbness and pins and needles to your hands and to your arms and legs, progressing to paralysis. You can see the little ventilator in the corner there. They often end up on a ventilator. The big critical problems first one is airway and respiration. They have difficulty speaking with very slurred speech because all the muscles of the face aren't working. Difficulty swallowing so they can aspirate. And bowel and bladder function, because remember the autonomic nervous system is also involved in this peripheral nervous system disease. Okay, biggest concern at the beginning, airway and respiratory arrest. Okay, so let's look at another condition called myasthenia gravis. And this is a condition at the neuromuscular junction, right? So where the nerves meet the skeletal muscles of the body. And this is an autoimmune disease, right? So it's antibodies that are attacking the acetylcholine receptors at the neuromuscular junction, so that when the nerves release acetylcholine, there's just not enough receptors to be stimulated and then activate the different muscles in the body. Okay? So what's going to happen to all of these skeletal muscles? Well, they're going to be weak. They're not being stimulated properly due to the lack of acetylcholine receptors. So there's going to be progressive weakness of all skeletal muscles. In particular, typically the eyes are affected first. So patients present with ptosis, which is droopy eyelids. They're unable to keep their eyelids open. And also double vision, because the extraocular muscles that move the eyes, those are skeletal muscles. So they don't move together. So patients complain of double vision. This will progress to the rest of the body as well. So difficulty moving the facial muscles, difficulty moving the tongue, symptoms of difficulty swallowing or chewing. But then it progresses to weakness of the arms, weakness of the legs, difficulty walking, And most concerning, it results in respiratory compromise. So the diaphragm and the intercostal muscles are also affected. So patients can get into trouble with ventilation and they can go into respiratory arrest requiring intubation. Okay, so that's by far the most concerning part of this illness when a patient presents. And remember, this is a chronic condition that patients live with for the rest of their lives. And they'll have exacerbations, so worsening periods of time with the disease, followed by remissions where it improves. And often their medications need to be adjusted based on whether they're having an exacerbation. Now, if you think of what's happening in terms of the acetylcholine receptors being destroyed, then the treatment will make sense. So we use immunosuppressant medications to suppress the patient's immune system, resulting in less antibody attack on those acetylcholine receptors, which will then result in more acetylcholine receptors. And that will typically result in a gradual improvement in their symptoms. As well, we use drugs to increase acetylcholine at the neuromuscular junction. So medications such as pyridostigmine, which is an acetylcholinesterase inhibitor, will allow more acetylcholine at the neuromuscular junction, resulting in improved symptoms and signs. So they'll have less ptosis, less double vision, they'll have more strength for walking or using their upper limbs, and as well, of course, the respiratory system. They'll be able to breathe independently and not require recurrent intubations. Okay, so the biggest system that is of most concern is the respiratory system when these patients present. So think of the treatment really as two-pronged. Immunosuppressants to reduce the amount of antibodies just destroying the acetylcholine receptors, and drugs that will increase acetylcholine at the neuromuscular junction. Okay? Okay, so we just finished talking about Guillain-Barré syndrome. But remember, peripheral neuropathies are extremely common, especially in diabetics. So diabetics get peripheral neuropathy. So what do they get? They get numbness in their feet as the most common presentation. So both feet and both sides are numb to their feet and their legs. And that's a problem. They can't sense, they can't feel things. So that's a very important issue, because they can develop ulcers to their feet just because something was in their shoe, for example, and they were walking on it all day, and it's cut open their foot. So diabetic neuropathy is damage to the peripheral nerves to the feet, because the little tiny capillaries that supply all these nerves get blocked in diabetes because it causes atherosclerosis. So they develop loss of these nerves and a peripheral neuropathy. You can also get this in renal failure. So patients with renal failure can get peripheral neuropathies. Alcoholism from a multitude of vitamin deficiencies can also have peripheral neuropathies. Chemotherapy drugs often really damage the peripheral nerves. So a lot of drugs can predictably damage nerves, and we typically know which ones they are, and we'll warn patients of, this particular chemotherapy agent for this cancer can cause significant numbness, tingling in your hands and feet. So that's the symptom we want you to watch for. Okay. So let's go on and talk about diabetes a bit. So what does it cause in terms of nerve issues? I mean, we know that diabetes causes many issues, but in terms of the nerves, what happens? So you get sensory loss, numbness, and tingling to the limbs, typically the lower limbs, the legs. And this lack of sensation will, so your sensation usually warns you to move your feet if you've been leaning them against something or if you're stepping on something. They lose that ability. They lose that sensation. So they're very prone to skin breakdown and ulcers, infections that can lead to amputations because of the infection. So diabetics, so nurses and healthcare professionals are very careful with the feet of diabetics. We always look at them when they come in to make sure that they're not infected from ulcers or cellulitis. Okay. Diabetes can also cause an autonomic neuropathy. So just like the peripheral nerves, diabetes also affects the nerves of the autonomic nervous system. So if you affect the autonomic nervous system because the nerves are being damaged because the blood supply is dying to them, well, you can get orthostatic hypotension, you can get fainting, you can get abnormal control of your heart rate, which is all the things that the autonomic nervous system does. Okay, urinary incontinence, sexual dysfunction. These are autonomic functions. Gastroparesis. So what is that? So gastro is stomach. Paresis is basically a similar term to paralysis. So gastroparesis is lazy stomach. It doesn't empty well. Very slow to empty after you've had a meal. So, and this is from the nerves that have been damaged in diabetes as well. So the enteric nervous system is also affected by diabetes, and they often have abdominal discomfort, bloating, and this condition called gastroparesis. And we use medications to try and stimulate the stomach to empty when they have a meal. So you can see all the different systems that are affected by diabetes, with the peripheral nervous system and the autonomic nervous system. Okay, so let's do this question together. I'm always a fan of questions. It helps bring information together. So Guillain-Barré syndrome is an acute autoimmune reaction that causes demyelination and paralysis. What is the specific expected pattern of paralysis of Guillain-Barré syndrome? So this is on one of the PowerPoints, and it's an ascending paralysis, right? So it often starts with weakness or sensory changes in your fingers and toes, and then quite quickly it ascends to the central portion of the body, right? So it's going to result in profound weakness of the skeletal muscles. Okay, so the demyelination of nerves is going to result in improper action potentials that are innervating muscles, and patients can quickly develop paralysis. And in particular, this can lead to respiratory muscle paralysis. And patients often need intubating, and they may need to be on a ventilator for months. Now, most people recover from this, but it can take many months to recover from this illness. Most patients get very close to their baseline functioning of what they had before the disease. Not everyone, but the majority of people recover over the span of many months. Okay, so So remember, this is a peripheral autoimmune disease of destruction of the myelin sheath. Okay, so I'll give you a case that I had about 3 years ago. So a young woman presents, and I think she was about 24, and she came in and said that she had a bit of tingling and weakness to her hands. Really couldn't find too much. Her strength seemed fine. She was walking in the emergency room. She was speaking normally. I didn't notice that she had any weakness anywhere. So she went home, and about 6 hours later, she came back with the same symptoms, but now she just felt that her legs were weak and that she was having a bit of difficulty walking at home. Now, again, while in the emergency room, yes, she had some pins and needles to her hands and feet. She was definitely walking normally. Her speech was fine. There was really not much to find. So we decided just to keep her in the emergency room and observe her. And within about 2 hours, she began to have difficulty breathing. She felt short of breath. She was still able to take normal breaths, but she just felt that she was working to take her normal breaths. And that then proceeded to become significant difficulty breathing. She couldn't even take normal breaths. And finally, about an hour or two later, she needed intubation because her oxygen saturations had profoundly dropped, and she couldn't maintain oxygenation in her bloodstream. So we intubated her. So this is how quickly it can happen. Now, just as a follow-up, she ended up being in an intensive care unit for 8 months. She was intubated for 6 months. She developed pneumonias. She developed pressure sores from laying in bed, even though there was a lot of care taken with making sure that she was being moved in bed. She was actually on a mattress, a pressurized mattress that was able to move and depressurize different compartments to try and avoid getting pressure ulcers. And then after that period of time, she required another 4 months at a rehabilitation hospital. And finally, she recovered about 90% of her baseline function that she had before developing Guillain-Barré syndrome. Okay, so it can be a pretty fast progression of the symptoms.